We're ready to call Insurance Full Committee to order this morning. So nice to see everybody on this beautiful spring morning. Mr. Clerk, take the roll, please.
Representatives Carr, Sapicki, Freeman, Hawk, Hicks, Hodges, Johnson, Lafferty, Mitchell, Powers, Rudd, Smith, Terry, Thompson, White, Vice Chairman Rudder,
Here.
Chairman Kumar. Vice Chairman, you have a quorum.
Thank you. Are there any personal orders from any of our members? Yes, Representative Smith.
Thank you, Chairman Ryder. I want to recognize my shadow intern for the day, Charles C. Mallory. If you wouldn't mind recognizing her, she is job shadowing me from parts of Sumter County.
Welcome. Representative Johnson.
Thank you, Madam Chair. I have a guest with me today from Stewart County High School. That's going to be my shadow, Cameron Cunningham. He's a senior. And he plays on the golf team. Thank you.
Welcome, Cameron. Any more personal orders from any of our members? Seeing none, our first bill on our calendar is House Bill 1195 by Representative Garrett. You're recognized. We have a motion and a second.
Thank you, Madam Chair. Thank you, committee.
I believe you have some amendments following this bill.
That's right. The first amendment is ending code 6147. It makes the bill. Then the second amendment that I'm also going to do, 6635, just deletes a portion of the first amendment. So if possible, I'd like to roll those two amendments into one.
We have to take them one at a time, and then we'll roll them.
That'll be fine with me.
Okay. Let's go with the first one you spoke of, I think 6147.
Yes, Madam Chair.
Yes. And do I have a motion? We have a motion and a second. All in favor? Any opposed? The amendment goes on the bill. And now then we're going to the second one, 6635. Yes. Okay. You have a motion and a second on both bills. Do we? Yes. And now that we're going to roll both of those amendments. Okay. We're going to vote to put 6635 on to the bill. All in favor? Any opposed? And now we're going to roll those amendments into the bill, all into one, into the bill. Do I have a motion in a second? We've already done that, so I think that is taken care of. Bang the gavel. Gotcha. Moving on.
All right.
Okay, Representative Garrett, you're recognized.
Thank you, Madam Chair. And let me explain, this actually happened to me, this particular circumstance. In late last year, I was ordered to have an MRI on my back. And that MRI, after 3 times it was rescheduled, I actually never received that MRI. And what had happened is that the insurance company was asking for additional information from my doctor. For whatever reason, my doctor did not get that request and it pended. So after 3 times of scheduling this and taking time off work, et cetera, I asked my insurance company if there was any reason why I did not realize that there was additional information being requested from my doctor. And the response was, well, we didn't have to. And I didn't think that was exactly right. I said, well, I've got a solution. I'm going to file some legislation that requires when there's additional information requested in a prior authorization setting, that additional information, that request has to be provided to the patient. So I have worked with the providers. I've also worked with the insurance companies, and the amendment that we put on the bill at first is the result of that work to require either a provider or an insurance company to provide within 5 days notice that additional information has been requested from either or. So with that explanation, I'll be happy to answer any questions the committee may have.
Questions have been called. All in favor? say aye.
Aye.
All opposed, no.
Thank you, Madam Chair and Committee.
Moves on to GovOps.
Next item on our agenda, House Bill 1398 by Chairman Helton. We have a motion and a second. Chairman Helton, you're recognized.
Thank you, Mr. Chairman and committee. House Bill 1398 will put patients back into the center of healthcare where they belong and give them more access, choice, and transparency. This bill does 5 things. Section 1, it addresses 340B discrimination. 340B entities are safety net providers that serve the state's most vulnerable populations. PBMs can amend a 340B entity's contract and reimburse at a lower rate than negotiated, essentially withholding money from indigent care facilities. The section of this bill will prohibit PBMs from discriminating against these entities so that the nearly 700 340B providers in the state can continue to provide services to the community without financial constraints. Section 2 addresses specialty pharmacy discrimination and patient steering. Many PBMs own or are owned by the pharmacies they require consumers to use. These PBMs steer patients to their preferred network of affiliated hospitals, providers, and pharmacies in order to maximize their profits. PBMs can mandate that you obtain your specialty infusion or other pharmaceutical drugs from their preferred specialty networks or PBM-owned pharmacies, even if the patient experiences adverse care through drug waste, incorrect dosage, or delays in medication. This section of the bill puts choice back into the hands of the patients, specifically those that are suffering with chronic, complex, or rare diseases. Section 3 addresses spread pricing and rebate retention. Spread pricing occurs when a PBM charges a health plan more for a certain drug than it reimburses the pharmacy dispensing the drug, artificially inflating the cost. This practice results in higher costs to the consumer while allowing PBMs to divert fees for profit. It is most common with cheaper generic drugs. PBMs receive rebates by offering different types of placement on health plan formularies. The rebate passes through the PBM to get to the plan, and the PBM retains a portion of the rebate as part of its contract. This section of the bill ensures the price reduction negotiated by the PBM passes through the pharmacy directly to the consumer, and that pharmacies are no longer paid below their acquisition cost. Section 4 and Section 5 addresses transparency. This provision states the PBM has a responsibility to report any entitlement benefit percentage to both the plan and covered person that either are entitled to. This section of the bill will remove the opaqueness within the PBM system by freeing up data to provide accurate information to patients at the point of care, empowering discussions and decisions about medications a patient can afford and what it is going to cost.
Thank you, Madam Chairman. We do have an amendment that we need to attach. I have a code 005618. We have a motion and a second.
Thank you.
I would assume that the bill that you described includes this amendment.
Yes, it does.
So members, you have heard about the amendment. And we have a motion and a second. Let's vote on attaching amendment 5618 to House Bill 1398. All those in favor, please say aye. Aye. Opposed? The amendment goes on the bill. Before we take up questions, it may also be good. We have several people who want to testify on this matter. So we will call upon them, and to do that without objection, we'll go out of session. First up on our list is Ms. Ashley Reed with TennCare. Ms. Ms. Reed, you know the system. Kindly introduce yourself and tell us what you think.
Thank you, Mr. Chairman and members. Ashley Reed, Division of TennCare. I will be speaking on Section 5 of the amended bill. This language requires TennCare or its PBA to report real-time cost, benefit, and coverage data in a format by the requesting party to the enrollee, enrollee's healthcare provider, or enrollee's authorized representative. There are no restrictions on the number of times data can be requested upon granting authorization, and there are no restrictions on a third party's use of data beyond the authorized representative. Near real-time data output on this scale is currently unavailable and out of scope for TennCare or our PBA's current system offerings. We also need to ensure that we follow HIPAA guidelines. TennCare's 3 MCOs would also have to implement and maintain a data system to share pharmacy-related data for physician-administered and inpatient medications, which would have a fiscal impact. Each MCO would have similar startup and ongoing expenses, as does the PBA.
Thank you. Can you summarize your feeling? Would this be good for TennCare or would it be a problem? And is that a problem that can be overcome?
Yes. So the crux of the issue is that what Section 5 would require us to do is it could allow for enrollee data to be shared with vendors or third parties, which would cause concern. There would also be a system build cost. We did provide some language that would help us, and I may ask Renee Williams, our Chief Pharmacy Officer, to come up and assist.
Ms. Williams-Clark, you are on our list, so kindly go ahead. Introduce yourself.
Thank you, Speaker and committee, for having me today. My name is Renee Williams-Clark, and I'm the Chief Pharmacy Officer at TennCare, and I'm a pharmacist by trade and have over 12 years' experience in pharmacy benefits management, 6 of those being primarily in the Medicaid space. And to address your question about whether or not the value from a TennCare perspective, we definitely believe that patients should have information and access information, and that's why we monitor and maintain 24-hour call centers for them to access information at any given time that they'd like to reach out and find out status about their claims. There are also information about what's covered and how it's covered, including step therapy quantity limits, readily available online and accessible and updated as frequently as monthly and anytime a change occurs to the program. And then members are also made aware at the time, say for instance, for prescription benefits, that there is a rejection. So they receive letters now as it is. With regard to Section 5, there is the requirement of both real-time infrastructure and exchange of data does come at a premium because claims are constantly being sent to these vendors to process. And to give you for instance, on the pharmacy side of the house, we receive over 12 million claims per month. Getting that information on a daily basis, and actually what the Section 5 calls for is real time, which is closer to near real time because that exchange of data multiple times through vendors, through secure networks that have to be created, does drive the costs around infrastructure and startup cost, and then ongoing maintenance. The system in and of itself is built as in modules, and those modules and build outs and each of them have their own contained space that have to be secured and monitored by IT personnel and security personnel on both sides of the space, constant updates, as you can imagine, because it is healthcare and protected information. And so connectivity has to then be built essentially between those two entities or parties exchanging the information, and secure connections have to be built and maintained in order to do that. There's also the point at which the output, we just talked about a lot about input. There's the output. The Section 5 indicates that The format would be the chosen format of the entity, individual, or personnel requesting it. And so that in of itself also poses a complex, nuanced specialty management and handling to be able to output in multiple formats at any given time.
Well, thank you. Now, it would appear to me that most of these systems about protecting privacy already exist and are in place.
Yes, those systems are for protecting privacy and
Sure.
in place on a weekly basis, sometimes daily basis. But when we talk about real time, we're talking about a claim for pharmacy transaction goes through in less than a second. And so transferring that data each time a claim goes through across the state for any given member at any given time does become a more complex process.
And that would be an addition because of this bill.
That is correct.
Chairman Smith, you're recognized.
Thank you, Mr. Chairman, and thank you all. One question I've got, patient privacy is important. It can be done because we track UPS packages, we do FedEx, we do these things. What I just heard is you're focusing on process. What Chairman Helton's doing, which I support, is focusing on patients. And so focusing on the patient to create a process where this data is available, where we're making sure that the cost to the patient is experienced. I get it. I'm with you. I'm going to be strongly supporting the bill, and I'm going to strongly encourage you all to work with our finance committee to find a way to make this happen. And thank you for showing us yet again why an all payers claims database is needed in our state, not just for tracking prescriptions, but also to have Tennessee-centric data that's available in a way that it can be manipulated and protected on an ongoing basis. So thank you, Mr. Chairman.
Thank you. Chairman Speaker, you're recognized.
Thank you. And I'm going to echo a little bit what my colleague did in support of this bill. So my question is very simple to you. If the General Assembly passes this bill in the current form, you will comply with the wishes of the General Assembly and make this happen, right?
Absolutely.
Thank you very much.
So next will be this person. Thank you. Members, any other questions? Ms. Reed, do you have anybody else that wants to testify on your behalf?
I do not.
Thank you for coming. Next person on our list is Mr. Trey Moore and Michael Power. Welcome, gentlemen. You know the buttons.
Good morning, Mr. Chairman, members of the committee. My name is Michael Power. I'm with the Pharmaceutical Care Management Association. We're thankful for the opportunity to be here today to speak to you on what is a very important topic as it relates to the pharmacy benefit. Unfortunately, we are here in opposition to House Bill 1398 in its current form. Before I get into just a couple of our key issues, I just wanted to give you a quick background on PBMs and in our role in the drug supply chain. We originally were started in 1970, 1980s to process drug claims. Drug claims have risen substantially over the years. I think in 2020, in the United States, we processed over 4.6 billion drug claims across this country. We have 270 million Americans who receive their pharmacy benefit through a pharmacy benefit manager, and 1.2 million of those folks reside here in the state of Tennessee. The business of a pharmacy benefit manager is business to business. We work with a client. The client could be a large or small employer here in the state. It could be the state itself or other industry sectors. Our role in the marketplace is to respond to a request for proposal that those people put out, and then we respond with the bid. We design all the plans and all the elements, including the formulary, based on requirements that the plan sponsor asks for. And so it is our responsibility to meet all the goals of those businesses here in the state, as well as the state, and provide a product that is not only beneficial to the beneficiaries of those pharmacy benefits, but also meets the budget demands of the companies, the state, and those other employers here. As it relates to House Bill 1398, I'll quickly sort of jump into some of our key concerns. Section 1, we haven't provided any comments on that. We're neutral on Section 1 of the bill. Section 2, as it relates to some language around any willing pharmacy or provider. Tennessee already has existing law on any willing provider here in the state. And so there are some new terms in this section. But outside of that, we're not really sure what the new intent is here because there is some existing law on the books that does apply to any willing provider and pharmacy here in the state. As we move into Section 3, the bill sponsor mentioned that the intent of this section is to look at rebates. It is unclear to us where specifically in this piece of legislation that you talk about rebates. Rebates are used by the PBM and also the plan sponsor to two things. One, the plan sponsor can choose to pass those rebates on to their employees, or they can use those rebates to reduce their monthly premiums, helping reduce their cost of their health insurance. And so, there's two tools that PBMs or the employer or the client uses with those tools. The other thing that she mentioned was spread pricing. Spread pricing is really a risk mitigation tool. What that allows is a business or the state to develop a plan where they can actually budget a flat rate for their prescription drug benefit. If they don't use spread pricing, they can go to more of an a la carte method, like where they have to pay for each drug individually, and it'll be challenging for that business or that entity to budget on a fiscal year because those costs could be high or low depending on the status of their employees or the people here in the state. The legislation currently in Section 3, when we talk about reimbursement to the pharmacy, the language in there actually says actual costs, which I think is something we could be okay with. But the problem in implementation there would be that for us to comply with this state law, if it actually does say actual costs like it does today, we would have to require that the independent pharmacy or pharmacist provide all of their invoicing data, including rebates, coupons, or any off-invoice discounts they receive either from the manufacturer, wholesaler, or their PSAO. And so we would have to get all that information so we could comply with this law. Section 4, we're not really sure if there's anything new there, but we're okay with sharing that information. Section 5, most of this information, not all, but most of this information is already readily available to the beneficiary. PBMs use sorry, I lost my place here, but there's Secure Scripts as well as RX Hub to help convey these benefits and what's going on in the pharmacy benefit space to the consumer. And so the 3 largest PBMs already participate in these programs today. And so a lot of this information that we're looking to address in Section 5 is already readily available to the consumer. And just real quickly, I'm probably running out of time. So in closing, as the entity that would be regulated under House Bill 1398, there are some issues and some gaps, and we feel like it would be somewhat challenging for us to actually implement this law in reality due to some of the lack of clarity and some of the definitions missing from the legislation. We ultimately also feel that this legislation will drive up costs not only to the businesses of the state, but to your citizens. A lot of these plan decisions that we're looking to regulate here will in fact increase costs to the citizens of the state. So for those reasons, we're respectfully opposed to this legislation.
Mr. Power, you're recognized.
Mr. Chairman, Trey Moore on behalf of PCMA.
Oh.
I just wanted to touch briefly on the amendment that's before you, which alters the bill as filed in 2 very specific and significant ways, in our opinion, dealing with Section 2 and Section 3. The original bill in both Sections 2 and Sections 3 just applied to pharmacy benefit managers, which would be us. The amendment now applies Section 2 and Section 3 to a PBM or a covered entity. Now, that's significant because a covered entity is defined in the code to include self-insured benefit plans. And to understand why that's so significant, I think we need to just a brief discussion on federal law called the Employee Retirement Income Security Act, or ERISA as it's known. I'll read you just sort of a brief explanation that I've pulled from the NCSL website, which I think sort of encapsulates it with regard to Section 2 that deals with any willing pharmacy laws. So, and it deals with the ERISA federal preemption. So, as with most state regulation of insurance, any willing pharmacy laws generally apply only to state-regulated policies, especially fully funded insurance. What they mean by that is your individual market and your small group fully insured market. and do not apply to self-funded insurance plans, such as those offered by the largest employers. ERISA creates rules and standards for employers who choose to offer pensions and health benefits to employees. ERISA prevents states from imposing conditions on such ERISA-protected health insurance plans, and this is known as preemption of state laws. So when we talk about a self-insured plan, we're talking about an employer, and it doesn't have to be a large employer, although traditionally they were your larger employers because they had the capital to do so. But you actually are seeing a lot more smaller employers move to a self-funded market using stop-loss insurance. But what a self-funded plan means is that they don't actually have insurance. There's no transfer of risk to the health carrier. They pay dollar for dollar every claim that hits their employees. Now, they may show up at the pharmacist with a big carrier, an insurance card, a United card or a Blue Cross card or a Cigna card. I don't want to leave any of them out. But they don't actually have an insurance product. What that carrier is doing in that instance is acting as a third-party administrator for that plan. So I would say that by including self-insured in this amendment, that is a market change from the policies of this state that we've had for a long time. There's questions, like I said, over whether federal law would even allow it. I think if that's our intent, then we need to make it clear on the record. If it's not our intent, then I think it would make sense to also clarify that we do not intend on including ERISA plans in the ending willing pharmacy provision, as well as the Section 3 of the bill with the reimbursement issues. But I'm happy to answer any questions. Final thought, two state laws in Louisiana and Texas that attempted to include self-funded plans in their ending willing pharmacy provisions were subsequently struck down. So,
Well, thank you. We have some questions. Representative Hodges, you're recognized.
So PBMs took over in the 70s and 80s, and just a history prior to that. Our drugs in the United States were a similar cost to the rest of the world. Then PBM stepped in and drug prices started skyrocketing. In the 90s, we've seen drug prices triple, continue to see, drug prices skyrocket. So besides seeing skyrocketing drug prices since your existence, what good have you actually done? What good have PBMs done for this country who's seen their drug prices skyrocket under y'all's management? And why would we possibly listen to anything y'all have to say? Thank you.
thank you, Representative. What I would say is that the order of that statement might be a little different, right? In that PBMs existed before the rising cost of drugs and in their traditional role process claims. I think once you saw list prices from drug manufacturers start to skyrocket, employers, plan sponsors, government, Medicaid programs look to PBMs to pool all of that buying power to help curb that. Now, granted, we have a long way to go, and I think there are a lot of federal laws that need to change with respect to the monopoly power that the federal government gives brand manufacturers and allows them to continue to raise prices. But we are doing our best to play our part in the system.
Representative Hodges.
Thank you. So I'm glad you agreed that prior to your existence, drug prices were equal to the rest of the world. And again, now they've skyrocketed. We're the only country in the world that has PBMs, and we're the only country in the world that pays such an enormous cost for drugs. And so I think that it's fair to hold PBMs who manage our drugs accountable to some degree, right? And so, yeah, it's just, again, hard for me to sit here and listen to anything you have to say and actually take you serious. Thank you.
Mr. Moore.
Thank you, Mr. Chairman. One key distinction, of course, is that other countries at the federal level or at the national level set their own prices for drugs. And so obviously we don't do that in the United States. We have to buy these drugs. Employers and governmental health, other plan sponsors are forced to buy these drugs on the open market. They don't have the benefit of a federal government that is setting a price nationwide. So, and that's why you don't see PBMs operate in those other countries, right? There's not a role for them there as far as driving down drug prices.
Representative Hodges?
Yeah, that's great response. I mean, I agree. I'd love to see us set prices federally, but at the same time, once again, you guys, manage the drugs of this country, and we've seen them skyrocket under your watch, and before you were in existence, we were relatively equal to those countries that do set prices, and we didn't at that time either, and we were still equal to them. So I'll just leave it at that, and thank you for your responses.
Anything? No. Thank you. Chairman Smith, you're recognized.
Thank you, Mr. Chairman. And is it fair to say that most PBMs are owned by insurance companies?
There are 66 different PBMs that operate in the marketplace. So there's a lot of competition in the space.
Representative Smith.
Thank you, Mr. Chairman. I know that there's 66, but there's about 5 that have about 80 to 90% of the market share. Is that a fair statement? And of those 4 or 5 that have 80 and 90% of the market share, those are indeed owned by insurance companies. Is that an accurate statement?
That is fair to say.
Okay. And one thing, just to follow up on the comments that were made earlier by my colleague, in other countries, the reason that there are no PBMs is because there's no insurance companies, because the government owns the healthcare system. There are socialized medicine. And so just to set that into the record, the reason that there are no PBMs in another country is because it's socialized medicine, which we find in this country, it provides less care. But relative to the here and the now, I do agree with my colleague that the cost of medicines have gone up over the course of time. So the question I'm asking of you, is it time for us to return back to not assigning benefits to anyone except the patient, so that the patient shops, so that the patient pays the bill, and the patient demands value and a reasonable cost? Because right now, what we have done is through the assignment of benefits going to the insurance plans, PBMs acting as intermediaries. It's a very closed loop, very vertically aligned. And there's a diagram right now in my office. Insurance companies own pharmacy benefit managers, which own specialty pharmacies, which own other things. And we're seeing this vertical alignment as the costs go up. And so is there a role, in your opinion, to return to the assignment of benefits to the patient so that the patient pays, the patient shops, the patient demands value, the patient demands transparency, and the patient demands care? Thank you, Mr. Chairman.
Thank you. Ms. Power, Ms. Moore, you want to respond?
Thank you for the question. I appreciate that. So you sort of started with what's going on in other countries around the world, right? So they're on a single payer system where the government runs healthcare. In the United States of America, we took a different approach. And a lot of companies provide healthcare as a benefit to their employees that they don't have to provide. They choose to provide it to make their workplace more attractive and a place where these people want to come and live and work. And they fund a significant portion of those healthcare costs. And so I don't think it's a simple question of should we just eliminate the PBM. The PBM is a tool that these clients use to develop their program and plans to benefit their employees at a large share of their costs. And so it is a challenging question. It's a unique situation. But you're right. The United States of America does stand different than other countries in the fact that we don't really follow a single payer system.
Chairman Smith.
Thank you, Mr. Chairman. And I would just like to read into the record, we hear a lot about expanding and moving to a socialized medicine government system. But what we have heard testimony today, and I hope everyone listening in the public, is that in countries where there is socialized medicine, there's no free market, there's no competition, and there's a closed loop, and it does away with private insurance. And while I have a very love-hate relationship, which let's not all clap on the back row back there, with insurance companies, we need each other. And I want to continue to fight for a free market that puts patients first And so with that, thank you, Mr. Chairman, for your indulgence, sir.
Thank you, Mr. Chairman. Okay, Ms. Moore?
If I may, just address the diagram in your office, which I've seen. I think, and there's a sentiment that because a PBM or an insurance company may have an affiliate pharmacy, that there's some sort of favoritism being played there. And I just wanted to, for the committee's benefit, to know that in 2019, Speaker Sexton actually carried a bill in public chapter, that is now public chapter 470, that reads in part, a covered entity being an insurance company or a pharmacy benefits manager shall not engage in a pattern or practice of reimbursing pharmacies or pharmacists in this state less than the amount that the pharmacy benefits manager reimburses a pharmacy benefit manager affiliate, so a retail or a specialty pharmacy that they own, for providing the same drug or dispense. So there's a law on the books now that, and it effectively eliminates any temptation to sort of play by home rule and pay an affiliate pharmacy or specialty pharmacy any more than we would pay any other player in that market space. So I would just add that for that.
I think we can talk a lot about it, but ultimately the decision is going to be made by the vote, I guess. Chairman Smith? Thank you. Chairman Hawk, you're recognized.
Thank you, Mr. Chair, members. And we've heard the explanation from the sponsor. We've heard the support from many of our colleagues in the room, and I voted in favor of this in subcommittee previously. I want you to give me, bottom line this for me, what your perceived intent of the legislation is, and where you perceive that we can do a better job in working in this system. So just as few words as possible. I know we need to move on, and forgive me, I got pulled away to another committee. If you've already addressed that, please bottom line the issue for me, Mr. Chairman, and our folks to testify.
Mr. Moore?
I guess in response, I think the intent is what the sponsor has read. We don't disagree, I guess, on the intent. I think our disagreements might be in what the intent is versus the language of the bill, and creating a whole new framework of laws that sort of do the same thing as laws that are currently on the books. I think we're sort of creating two different sections of the code with this bill, where instead of working within the existing laws that already, for instance, say that we have to treat independent pharmacies the same, that we have to pay them the same, that we have to let them in the network if they want to be in the network. That is all existing law. There's some new language specifically in section 2 that mentions inducement or steering. Mm-hmm. It's our understanding that that's covered by existing law, but to the extent that we want to enhance that, I think, it would make sense to do so within the existing any willing pharmacy statute. With regard to self-insured plans, honestly, we were unclear as to whether that is the intent of the bill to include self-funded plans or not, because it uses a term, like I said, covered entity, which is very broad and basically is the whole world of health benefits. So my point would be, if we are intent on including self-insured ERISA governed plans, then I think it might behoove us to clarify that either in the law or on the record. And I would.
Discussion can get very long, but remembering the basics, if we will, one part of this legislation is discrimination against 340B entities. Those are entities that receive help from the government to purchase medications and drugs for those who cannot afford. I think that's a noble cause. In that situation, why would you have any objection to that?
We haven't objected to section 1, and I think his comments at the beginning, and sorry if we were unclear, meant we were neutral on that. We didn't work against the standalone 340B bill.
I had hoped you would go beyond neutral and say we support that.
Well, I guess my only response to that, Mr. Chairman, would be that we're neutral because we think it basically codifies current practice. No, we do have reluctance anytime you set a price control in statute and set a price floor, but it's our understanding that most of our members are already paying at that price floor or reimbursing at that price floor. So that's why we haven't had an issue with it.
Let's go on to the next point again in the legislation, and that is patient steering. Does that exist?
Well, I guess it would be our understanding of the existing law that we can't offer them a better price. We can't offer another pharmacy a better price under the existing laws of the state. So to the extent that there is steering going on, I guess it would just depend on how you define steering. Is advertising steering? Hey, come to, Publix and fill your pharmacies while you get your groceries. I don't know if that's steering or not, but to the extent that the reimbursement is steering, existing law, as I just read, and Any Willing Pharmacy dictates that we treat everybody equally in that space.
This depends on how you interpret steering. Reminds me of a famous phrase which says it depends on what the meaning of the word is. Remember?
Exactly.
Going on to the next point about paying pharmacies below their acquisition cost doesn't seem fair. Public does not like it. To us, it's fairly clear and obvious, and it costs pharmacists who serve small communities and towns. That really should not exist. Are you agreeable to that?
Real quick, just so the way the language reads in Section 3C of the legislation right now, and the substitute that y'all have before you, it actually says reimburse them at their actual costs. And so I do think that'll present some challenges. There are some, national average drug acquisition programs out there that have sort of the average cost. And what's important to note when we talk about spread pricing, in particular in this section, is that there are some drugs where the independent pharmacists, we reimburse them. We actually lose money when we reimburse them. And so it is sort of a seesaw, if you will. There are some drugs that they do get reimbursed below what maybe their acquisition costs are, but there are others where they get maybe reimbursed 2, 3, 4, 10 times their acquisition cost. So it is a back and forth.
So the pharmacies remember where they got underpaid, and you remember where you think you overpaid. But your prices are not clear in that sense, that you don't reveal what you purchase drugs at. In that sense, yes, Mr. Moore.
Well, I guess the only thing I would add to that is on aggregate, and this comes from the Independent Pharmacists National Trade Association. They publish an annual report every year, and in their latest one, on aggregate, they have about a 22 to 23% margin on the drugs that they sell. So while there may be some fluctuation, and it really, because prices, 9 out of 10 drugs that they fill are generic, and they're multi-source drugs, and in that sense, they are actually more of a commodity than anything else. And those prices fluctuate with supply and demand, like any other commodity.
Thank you. Representative Lafferty, you're recognized.
Thank you, Mr. Chairman. It's been a few minutes. I've lost my train of thought. I wanted to back up. Sorry, got it back to spread pricing. The idea, obviously, with insurance is we want to dilute our risk as much as possible. That's why we participate and purchase insurance. It's also part of the reason that we lose sight of cost. That goes for drugs, medical care, auto insurance, any number of things, because it's no longer in our view on a regular basis. And as consumers, if you don't see it, it's already been taken out of your check, the money to pay for it, you don't really care that much. With spreading the risk to everyone, is there a way, how do we get, and I guess maybe I know the answer. I'm trying to ask, how do we get people more aware of what the actual price of these drugs are before they go shopping for them from that commercial that they saw or that special that's running in the pharmacy window? Or is it just flat out that the consumer at the end of the day, if they don't have eyes on it, nothing's going to change? That's a convoluted question. My apologies.
Mr. Powers.
Thank you, Mr. Chairman. So, every year when you renew your health insurance plan, you get a plan documents that describe the benefit, including your health insurance and then your drug benefit. And then there are tools. Like I mentioned in my testimony, the 3 largest PBMs, you have RX Hub, which is actually an app you can put on your phone, and you can go through and search these things as well. And then there are often times when I go to the doctor, I'm often told what my prescription is, and they remind me that, hey, this one may be expensive. When my wife was most recently pregnant, she had a lot of nausea, and the nausea medicine that she needed, the doctor told us right away that this one's going to be expensive. And so there is those opportunities of communication, and it is, sometimes you have to be your best advocate, right? Sometimes you have to fight for yourself. I've been there.
Representative Lafferty. Chairman White, you recognize.
Thank you very much, Chairman. I don't know if this question can be answered right now, but just a thought for discussion as we move through this. While I'm complete agreement with my colleague to my right, who brought out, I believe that the free market system is the best way to control prices. I think we all believe that. My question is, since healthcare is such a convoluted and complicated issue that we've done to ourselves over the last couple of generations, is there anything out there that would prevent the free market from protecting the consumer? I'm a big supporter of the independent pharmacists, but is there any control out there that would allow the free market to work the way it should work in this issue? Do you have any thoughts or comments on that?
Thank you, Mr. Chairman.
Mr. Moore.
So I guess when you talk about the free market and most importantly, how the free market may drive down costs, but also improve quality, like you see in many sectors. The key there is competition, right? And I think where healthcare lacks in many cases is either federal or state regulation that actually hinders the competition within the marketplace. Now, some of that is just, a pure policy trade-off that legislatures determine. For instance, an any willing pharmacy law that is currently on the books that requires the person paying for the drug to do business with anybody that wants to do business with them, regardless whether or not they want to do business with that entity, right? And at the federal level, you don't have competition, or what we would say you don't have as much competition in the prescription drug manufacturing business because of patent laws and FDA exclusivity rights that manufacturers enjoy. They get a pure monopoly for 5, 7, 12 years under federal law with no competition. And they know that they're not going to have competition for 5, 7, 12 years. They also have the ability to sort of extend that exclusivity and that monopoly by tweaking, let's say the way the drug is delivered. The EpiPen is a great example, and y'all are all familiar with. So it's a balance as policymakers, I think, in taking care of your community pharmacies, like you said, in a way that also doesn't stifle competition. I think we're just here to speak to that balance, if that makes sense.
Chairman White. Okay. Chairman Powers, you recognize.
Thank you, Mr. Chairman, and thank you all for coming out today. Just briefly, and I don't want to take a whole lot of time, but could you talk a little bit more about the rebate system? I've never really understood what the original intent of it was and why it is needed when we're dealing with, and you don't see that in very many business models, and so I just wanted to get a handle on that.
Thank you, Mr. Chairman. Thank you, Representative Powers, for that. And we do hear a lot about rebates, and it's talked about as if rebates are ubiquitous and apply to every drug. To sort of set the baseline, over 92% of the drugs that are filled at a pharmacy counter are going to be generic, right? So that's a multi-sourced drug, and someone would have to point to me a situation where a multi-source drug would have a manufacturer rebate. I think where rebates come into play are more with brand drugs that are single sourced, right? So just the manufacturer is making that specific drug, and there may not be any competition in the market. To the extent that there are competing brands, you would see manufacturer versus manufacturer of different brands negotiating with PBMs for a better position on the formulary to increase their sales and their utilization. But if you think about it, the PBM, are not actually buying the drugs directly from the manufacturer. We are technically buying the drugs, we're paying for them at the pharmacy counter, and our reimbursement, either on behalf of a plan sponsor or a carrier, is going to the pharmacy. So really the only functional way for the manufacturer to discount specifically to us without lowering their list prices, which they seem unwilling to do. The only way for them to give us a discount is to bypass that supply chain and to give us a rebate. It would be no different from going into Best Buy and wanting to buy a new Samsung TV. Samsung doesn't want to lower its list price, but they may offer a rebate on that TV when you walk in for a period of time to induce you into buying it. But it's not Best Buy, but your money's going to Best Buy. You're not buying that from Samsung directly, so that's why the manufacturer, same with vehicles.
Chairman
Just one other
Powers.
thing real quick. Is it based at all on volume? Does that have anything to do with the volume of it?
On
The amount of purchasing volume
why they would give us a
on
rebate?
the rebates, right? Yeah.
Typically, yeah, right. So, so PBMs pool all of these covered lives together from different carriers, different employers. Then they go to the manufacturer and they say, you know, we can put your drug in a preferred position on the formulary because we got to put one of them on the formulary, right? I mean, we're committed to providing the therapy, and you know, if that drug manufacturer would then offer discounts based on how many basically units we can almost guarantee that they're going to sell or likely to sell. So the more we bring to the table as far as potential sales utilization, the more they're going to discount it. But it is going to be discounted retroactively, right? It's based off of sales. So there is like a 6-month lag typically, I would guess, on rebates because it's based on how many units are actually sold to our members.
Okay. All right. Thank you. Thank you, Mr. Chairman.
Yes, Mr. Power.
Thank you, Mr. Chairman. I just want to add one thing there too. It's also important to note that rebates occur almost at every stop in the system. The manufacturer provides them to the wholesaler. They provide them directly to the pharmacy, the hospital, but they also provide them to the PBM. They provide them to the state government, and they also provide rebates to the PSAO, which is an entity that has been formed to provide independent pharmacies and pharmacies very similar services to a PBM, and those entities also partner with us for their drug benefit. So there's a lot of rebates in the system.
Okay.
Chairman Powers.
Chairman.
The other thing that we didn't cover is the problem with price transparency. Can you explain that? Do you see a solution to that criticism?
Thank you, Mr. Chairman. So I think there's, we'd be willing to meet with folks on some transparency related issues. The one problem we have with, potentially like there's been some attempts in some places to release trade secret information. And that would be a problem when we're trying to bid on a new contract to actually drive down costs. If all the competitors in the marketplace know everything that we're doing, they'll just say, hey, we're going to give you that deal over there. And we'll lose our ability to negotiate a better deal on behalf of either the plan sponsor and those beneficiaries. And so there are elements of transparency that we can certainly work on. And we're happy to have those discussions. But there's just certain places that if we go that far, we will in fact raise drug costs.
And
Go ahead, Mr. Moore.
I would only add that our focus on transparency thus far has been towards the patient. I think anything that we want to do as a state to increase transparency for the patient, I think we're happy to support and work with you on. I think our biggest issue with Section 5 is that it seems to be promoted not by someone on behalf of a patient, but on behalf of a company that was purchased by a top 10 Fortune 500 company that is looking to monetize on this data. And we have yet to see a problem in there that needs to be addressed by legislation, I think. But to the extent that we want to drive transparency to the patients, we fully
Kindly
support that.
Put it in a more clear terms. What do you mean transparency towards patients? Patients don't know what price the drug was bought at.
Well, I guess what price that the patient is paying or what price that their plan sponsor is paying for the drug. I guess.
What transparency do you offer the patient when you talk about transparency related to patients?
As Michael alluded to earlier, so the vast majority of PBMs, especially the biggest PBMs that serve the most lives, utilize tools currently and pay for tools. He mentioned SureScript, which is a tool out there in the marketplace that most of the PBMs use. There are other tools out there, but essentially the goal of that is to put all of that information for the patient, cost information, formulary information, in the patient's hand, on their, smartphone, so to speak, so that when they're sitting in the physician's office and the physician says, we're going to prescribe you Humira, that the patient can look up Humira and see where it is on the formulary, see how much it's going to cost them out of pocket, and then give them the opportunity to say to the physician, is there something else, or is there something that we can do to help me with the cost there?
Thank you. Representative Mitchell, you're recognized.
Yeah, thank you, Mr. Chair. But my idea of price transparency would be, when as I work for a third-party administrator and I send a plan design out to a potential client, I have the cost of, what their stop loss is going to cost them, their stop loss insurance. I have the cost of our admin of their claims. I have the cost of the broker fee if there's a broker. I have every line item of commission is going through there. I think what the Mr. Chairman would be suggesting is, okay, you got this drug at this price. You got a rebate of X. You offer to the TPA X percentages of your rebate to contract with you, and you're charging X amount per script that goes through that ERISA plan for them. I think that would be the price transparency. Most of the rebates, most TPAs, when they get the money, they send most of it back to the client. So that is cutting into the cost of healthcare for most TPAs. Some TPAs pocket all or some of that, but that helps. That would be the price transparency I would think of. And when you suggest, read the plan document, as well as I do, there's not a person in the audience behind you, and there's not a person on this dais that has read their plan document for their health care. That's the case. So to even suggest that, let's be better than that. Thank you.
Thank you, Representative Mitchell. You put it in more clear terms. Thank you. Yes, Mr. Power.
Yeah, I did not mean to be misleading. For example, this year I did actually read through my document and picked a higher plan to get a lower monthly premium. And 1 month in, my daughter broke her arm. So I was immediately bit in the backside by having to pay a pretty hefty cost to have a repair done to her arm. And so I wouldn't have said it if I didn't do it myself. Thank you.
Representative Mitchell.
You may have read an SPD, a summary plan description. You did not read the plan document. You did not read every. Let's be serious. You've seen plan documents, and you did not read that plan document. You read the summary plan description.
Yes, Mr. Moore.
If I may, and that's why we also use tools like SureScript that I was mentioning that puts an app on a phone for an enrollee so that they don't have to read the plan document, but they can still get all the information that they need. So that's all.
Well, thank you, gentlemen. Any more questions for them? Thank you for coming.
Thank you.
We also have one more testifier, Dr. Stephen Schleicher. Or is it Schleicher?
Mr. Chairman, he's not going to testify today.
Okay. Well, thank you. Then that ends testimony. We will go back into session. We are back on the bill 1398 as amended.
Can I say something in closing, Mr. Chairman?
Certainly.
Okay. For the year 2021, 81 bills have been proposed in 29 states related to pharmacy benefit managers' practices. There has been much concern in Tennessee regarding PBMs, but little action. Mr. Chairman and members, now is the time to take action. I renew my motion.
Thank you, Chairman Houghton. We do have a motion. Question's been called. the question's been called, so that cuts off all debate except for the sponsor. And the chair lady has had her say. Without objection, members, we are voting on House Bill 1398 as amended. All those in favor, please say aye. Opposed? The bill goes on to the Finance Committee. Thank you, Madam Chair.
Thank you, Mr. Chairman and members.
Next item on our agenda is item 3. We are making slow progress. That is House Bill 10979 by Chairman Williams. Chairman Williams, we have a motion and a second.
Sorry. Thank you, Chairman and members. I have an amendment, I think that we put on subcommittee. We don't have to put it back on, correct?
Yes,
Okay.
it's traveling with the bill.
No, I think,
We have to put it back on.
yes, drafting code 005743, which amends the bill.
So we have a motion and a second on the amendment. Without objection, we are voting on Amendment 5743 going on House Bill 979. All those in favor, please say aye. Opposed? The amendment goes on the bill. Chairman Williams, you're recognized.
Thank you, Chairman Kubar and members. This bill would allow for auto enrollment for long and short-term disability plans for businesses across the state. Employees can still unenroll within 30 days. And again, I think at 60 days. This bill also creates an F&E tax credit for those employers who do participate in these plans. As the members know, this year COVID has impacted lots of citizens across the state. If they had been enrolled in short-term or long-term disability programs, it would have been better for them and their families. This bill allows them to be automatically enrolled with the idea that they can be removed just by simply requesting that within the first 30 days of employment. With that, Mr. Chairman, I'm happy to answer any questions.
Thank you. Representative Thompson.
Thank you, Mr. Chairman. As I spoke in subcommittee, I've in past work roles, I've dealt with employees who have been in short-term and long-term disability, those who did and those who didn't, and then the effects of those people when they became disabled. And this is very much to the advantage of employees all over the state. And commend you for the bill, and I support it fully.
Thank you, Representative.
Representative Lafferty, you're recognized.
Thank you, Mr. Chairman. This is just for my own knowledge. I probably just curious. Could you give a little bit of color about how the F&E tax credit would work for the businesses, please?
Yes, I appreciate you asking me that question. The F&E tax credit would be for the businesses because they're automatically enrolled into those. This would give a credit for those that are that would be employed there. I think the challenge for their corporate tax, for F&E tax, it's an incentive for businesses to participate in these programs, for them to do it, and that's the reason why it's in the bill. It is probably, if found favor in this committee, it's also the reason why it might not succeed in finance, but it is definitely an interesting component that other states have done as well.
Any more questions, members? Well, thank you for bringing this. Really, for working families, disability income is very crucial as things happen in life. Seeing no further questions, without objection, we are voting on House Bill 979 as amended. All those in favor, please say aye. Aye. Opposed? The bill moves on to Finance. Thank you. Next item on our agenda is House Bill Item 4, House Bill 1463, Representative Cochran. We have a motion and a second. Representative Cochran, you're recognized.
Thank you, Mr. Chairman. House Bill 1463, while it reads like a caption bill, it actually does exactly what it says. It simply clarifies our assignment of benefits code, and it basically, this bill is clarifying that our assignment of benefits code does not prevent this type of insurance plan, which would be if a patient went to a doctor and wanted to pay cash and get that cash discount and then be reimbursed by their insurance company. So there seemed to be some confusion in the insurance market whether or not that type of plan was allowed. This is simply clarifying it.
Well, thank you. Members, you have any questions? Questions been called. Without objection, we are voting on House Bill 1463. All those in favor, please say aye. Opposed? The bill moves on to calendar rules.
Thank you, Chairman and
Thank
committee.
you. Item 5 is House Bill 0556 by Chairman Johnson.
Thank you, Mr. Chairman. There is an amendment that makes the bill.
Is that amendment 4425?
Oh. 5906.
5906, okay. We have a motion and a second on amendment 5906. All those in favor of putting the amendment on House Bill 556, please say aye. Opposed? Amendment goes on this bill. Mr. Speaker, you're recognized.
Thank you, Mr. Chairman. House Bill 556 is the annual nursing home bed assessment. This bill renews the annual bed assessment through June the 30th of 2022. And it's typical that this fund funds about 1/3 of the nursing home Medicaid budget.
So it is about $134 million.
Yes, Mr. Chairman, but it draws down $264,758,000 federal funds.
Seems like a good deal. Members, do you have any questions? Seeing none, we are voting on this annual assessment, House Bill 0556 as amended. All those in favor, please say aye. Opposed? The bill moves on to the Finance Committee. Thank you, Mr. Speaker. Next is item 7.
6.
House Bill 0619 by Vice Chair Rudder. I'm sorry. Did I? What do we do? I say I'm sorry? Well, it's a parliamentary thing. So I skipped item 6 and my apologies. We will roll it back and deal with item 6. Why am I not finding it here?
It's because
Chairman Hawk, my apologies, it's about the page, okay. House Bill, item 6, House Bill 0360 by Chairman Hawk.
Thank
Do
you,
I
Mr.
have, do I have a motion and a second? Thank you. Chairman Hawk, if it's okay with you, we'll go ahead and place the amendment on the bill.
Thank you, Mr. Chair. And the drafting code is 5070, I believe, is the one that we want to adopt in full committee, Chairman.
That is true. We have a motion and a second. Without objection, we are voting on adopting Amendment 5070 to House Bill 0360. All those in favor, please say aye.
Aye.
Opposed? The amendment goes on the bill, and Chairman Hawk, you're recognized on the amended bill.
Thank you, Chairman and members. And House Bill 360 as amended by Tracking Code Amendment 5070 seeks to give our Tennessee Department of Commerce and Insurance a broad perspective on how insurance plans are doing when it comes to covering mental health care issues in insurance across the state of Tennessee. This bill directs Tennessee Department of Commerce and Insurance to use existing resources to access federal reports from insurance plans to make this data available to us, the General Assembly, and report. as we've worked through this, we adopted a different amendment, had the same context to it, but had some preamble clauses, some whereas and what for clauses in it. And I had a 50-50 chance at picking the right amendment last week in subcommittee, and I picked wrong. So this amendment that we have is the same intent, the same language as we passed in subcommittee last week. It just removes the whereas clauses and is the same as the Senate. So with that explanation, Mr. Chair and members, that's what the bill does.
Representative Lafferty, you're recognized.
Thank you, Mr. Chairman. Is this primarily just a reporting bill right now to see where this goes down the road?
Yes, it certainly is. It's a reporting bill, and it's reporting of some information that's already been deemed as important. We've been working on this for 5 or 6 years to get a concise document that has parity, insurance parity on coverage of mental health issues. We've been working for a long time on this. The feds jumped up and said, we're going to go ahead and collect all this data. So it's just a matter of us retrieving that data from the feds to bring it to us to make good decisions in the future. So in a nutshell, it is a reporting mechanism.
Thank you, Chair. Chairman Spicky, you're recognized.
Thank you. And just kind of clarification, trying to figure out why this would have a fiscal note on it at all.
Chairman Hawk.
In the onset, there was thought that the Department of Commerce and Insurance would need another employee to retrieve this data. We were reminded Department of Commerce and Insurance that, as I mentioned in this 5-year process, we've been working on this. The General Assembly had already created a funding mechanism for this several years ago. So there was an initial fiscal note placed on the legislation, but in retrospect, seeing what we've already done as a General Assembly, that was not needed because that funding is already there.
Okay.
Chairman Speaker.
Fine, good, thank you.
Any other questions? Seeing none, and without objection, we are voting on House Bill 0360 as amended. All those in favor, please say aye. Aye. Opposed? The bill goes on to Government Operations Committee.
Thank you, Chair and members.
Thank you, sir. Item 7, House Bill 619. Vice Chair Rudder, you're recognized.
Thank you, Chairman Kumar and committee.
We have a motion and a second.
House Bill 619 would require insurance companies to apply the value of drug coupons to their enrollees' deductibles. Many patients across the state, especially those with chronic complex conditions, rely on copay assistance programs to afford their medications. These programs offer vital financial assistance to help cover out-of-pocket prescriptions. As copays have increased steadily over the years, these programs have become more important for Tennesseans. House Bill 619 makes sure that the value of these copay assistance programs counts toward patients' annual deductibles. I hope that you will can support me on this bill and help our patients in the state of Tennessee. I will say that this passed out of Pensions and Insurance with a unanimous positive recommendation. With that, I'll take any questions.
Thank you, Vice Chair Rudder. We do have people who want to testify on this matter, and we are familiar with the gentleman, Mr. Moore and Mr. Power. This is Act 2. Well, gentlemen, thank you for coming. We will go out of session, and please proceed with your testimony. Thank you.
Thank you, Mr. Chairman, Vice Chairman Rudder, members of the committee. I will try to be brief. And I'm on behalf of PCMA again. We do not disagree with the intent or the sentiment behind the bill at all. In our perspective, the language is a little broad in that it might have some negative sort of unintended consequences. And If you'll allow me, I'll just take a brief moment to explain it. In 2005, this legislature passed the Tennessee Affordable Drug Act. And what that said in part is the General Assembly declares it to be the public policy that in order to lower the cost of prescription drugs to its citizens, pharmacists may substitute less costly generic drugs or drug products for higher priced brand name or trade name drugs. That law goes on to dictate, actually, in some cases, the pharmacist shall dispense a lower cost generic or a lower cost brand if it's available in the pharmacy and is a bioequivalent. From our perspective, I think we certainly understand when there is a high cost brand name drug on the formulary and it is the only drug that the patient can take, that a drug coupon should be used to help that patient offset their costs. I think our issue with the language is in a scenario where that drug coupon is used to get a brand name drug where there's either an equivalent brand or a bioequivalent generic on the formulary. And we'd be happy to work with the sponsor on amending the language to address that concern. I would add that 10 years after that law was passed, the Speaker Sexton carried a bill that had to do with biologics and biosimilars. It amends that same section of the code and deals with sort of these high-priced biologic drugs and now that are going off patent, and you have some competition now through biosimilars coming on the market. We think addressing that in this bill would be good for patients and the state as well. But to the extent that there's just a single source drug on the formulary and the patient it has to have that drug, then I think it makes sense that that the coupon be honored in the sense that the bill intends. So.
Chairman Smith, you're recognized.
Thank you, Mr. Chairman. Just for clarity, and this may be directed also to the bill sponsor later, but so because I support this notion of particularly in the day of these biologics that are $2,000 and $3,000 for a month's supply. But so what I'm hearing you say is if someone presents at a pharmacy and they have a drug coupon for drug X, and drug X also has a biosimilar or a generic, that there's nothing currently that would allow the pharmacy to dispense the biosimilar or the generic once the patient presents that coupon, or
under current law, if I may, Mr. Chairman, the actually current law, then the two laws that I was referring to would actually direct the pharmacist to do that. I think what the sponsor is getting at is sort of a back end carrier issue with cost sharing and how that's applied to the deductible, whether the coupon, if essentially paid on behalf of the manufacturer, would go towards the patient's deductible. And I think our concern is that we only have a few tools to sort of drive people towards lower cost drugs, especially, generic and bioequivalent or biosimilars. Cost sharing is just one of those tools. So I think if I understand the sponsor's intent, it's to get at those exceptions where that may not work for the patient. And I think we're amenable to addressing that without sort of throwing the baby out with the bathwater on generic and biosimilar utilization. But.
Yes, Chairman Smith.
So let me make sure I understand this right. So you're happy to accept the bill sponsor's premise unless there is a biosimilar or a generic.
Correct. And I would add that Kentucky passed a law that addressed that issue with respect to generics. I think we supported that in Kentucky, and we do here. The only thing that I would add to that is this issue of biosimilars, just because this legislature has been out front sort of wanting pharmacists to utilize those.
Thank you, Mr. Chairman.
Members, any other questions? If not, we will go out of session. Oh, forgive me. Chairman Terry, you're recognized.
Thank you. I just, to your point about if there's a biosimilar or a generic, And this goes to the question that we've had on other issues in here about medical necessity. Just want your take on this. If a patient has been stable on a medicine and the next year comes up and then they have a coupon on the medicine that they're on, would you not think that that should be applicable to their to this bill?
Mr. Moore?
Thank you, Mr. Chairman. And Dr. Terry, yes, assuming that, the generic bioequivalent in the physician's, discretion, it does not work well, right? And there are laws on the books currently in that section I referenced, right, where you as a physician can write dispense as written, right? And that directs the pharmacist not to substitute for the biosimilar or the generic because for whatever reason, the brand is necessary and the generic won't work. I guess my point would be that would be an exception typically to how generics work, right? And so we're just happy to work through that exception without unnecessarily limiting the uptake of generic and biosimilars.
Thank you, Chairman. I just, yeah, it's something we need to work on. Thank you.
Representative Lafferty, you're recognized.
Thank you, Mr. Chairman. Are the coupons issued primarily by the manufacturers? Okay, so that's not something that's provided by the PBM or any other.
Yeah. Any other questions, members? Oh, sorry,
If I
Mr.
may.
Moore.
That's correct, Representative Lafferty. So coupons in the Drug Space Act, like they do in the rest of the world, right? It's a coupon from the manufacturer to encourage someone to get a drug. Now, when you talk about these high-priced biologics, it behooves manufacturers to help a patient afford their cost sharing in order to sell the drug, which they can make that cost up from the plan when they purchase the drug, even giving that discount to the patient on the front end. So when we talk about these biologics and specialty drugs, the average annual cost of a specialty drug is like $80,000. So,
Representative Lafferty. Okay. Members, any other questions? Seeing none, we will thank you, Mr. Moore. We'll go back into session, and we are back on House Bill 0619. Vice Chair Rutter, you're recognized.
I would just like to say that my intent is very elementary on this piece of legislation. That coupon has value. The value of that coupon should go toward the patient's deductible. These patients sometimes have catastrophic deductibles. That's the only way they can have insurance. These coupons have value. You spoke of 2005, and you were, you were to lower cost to the citizens. That hasn't happened. Our citizens are not getting lower cost drugs. When a doctor prescribes a medication to a patient and gives them one of these coupons to help them with offset the cost, I think that the patient should be able to receive the benefit of that toward their deductible. They shouldn't have to make a decision about whether after that coupon expires and they can't pay their out-of-pocket to go without the medication. This helps lower those deductibles so those patients get the medication that they need. And it also smacks a little bit to step therapy to me when you talk about the formulary and let's try this first or that first. We're getting between the doctor and the patient. So that is my closing statement. I ask you to support the patients. It's good for our patients in the state of Tennessee. They should receive the value of that coupon. Thank you.
Thank you. Representative Mitchell, you're recognized.
Yeah, I appreciate it, Mr. Chairman, and sponsor the bill. I support your bill, but this just kind of proves the point that, the drug companies are overpricing their drugs, so they're able to give a coupon to, take away a little of their profits. But unfortunately, what we're doing with this piece of legislation, instead of going after the drug companies, we're making someone else pay for the drug company's greed. And so, it's good for the consumer, but someone else is paying the price for someone else's greed. Thank you.
Thank you. Representative Lafferty, you're recognized.
Thank you, Chairman. I feel like I've taken a disproportionate time on this microphone today, so thank you, committee, for putting up with me. I think I co-sponsored this bill. I think I put my name on this bill. Sitting and listening to this, as tied together as the pharmacy benefit managers are, the manufacturers are, the insurance company, the health, and this isn't poking at any one. We've created this over the decades. All right, let's recognize that. My concern is, will the coupons dry up? If we enact this, will they go, all right, we just won't do coupons anymore. We'll just discount it. I just wanted to get that on the record.
Vice
Thank you.
Chair Ritter.
It's my understanding that drug companies are the ones a lot of times that supply these coupons. So I don't see that the coupons would dry up because they're always going to have a new product on the market, a better solution. And that goes back to the discussion between the doctor and the patient as to what that doctor thinks is best for that patient. So I don't think there's an issue with drug coupons and that benefit drying up.
Representative Lafferty. Oh, thank you. Members, any other questions? Are we ready to vote? Without objection, we are voting on House Bill 619. All those in favor, please say aye. Aye. Opposed? Silence. The bill moves on to the Calendar and Rules Committee. Thank you. Considering it's 10:29, members, we will adjourn and resume our calendar next week. Sorry? Item 8 is rolled to next week because of time constraints, and we stand adjourned. Thank you.